sex during pregnancy? Yes, no.
There's some people that just really are like, it's either the patient or the partner who are really squeamish. Like they think that the fetus is going to know what they're doing.
Hello and welcome back to HERology, the Mount Sinai Health System's newest video podcast. I'm your co-host, Dr. Lala, and today we're talking about pregnancy. What makes a healthy pregnancy? What symptoms are the most serious? And what are the most common things people wish they'd known following their pregnancy? To help answer these questions and more, I'm joined by our regular co-hosts, Dr. Joanne Stone and Dr. Barbieri. Welcome. All right, well, I'm so excited to be here with you both. We're going to be talking about the healthy pregnancy. I have so many questions for you both. As a measly cardiologist, I can tell you I've been through 2 pregnancies, but I have so many questions that I hope you can answer for both me and for our audience. Maybe we'll start with you. Okay, if I call you Joanne.
Please do.
Why do we focus, when we talk about the healthy pregnancy, when I think about that, I think about the 9 months. What does a healthy pregnancy mean to you?
It's such a good question because it's sort of like the polar opposite of what I get asked, which is what's a high-risk pregnancy?
Right.
Which is, could be anything. Could be anything from, somebody's 35 to somebody has terrible heart disease. But I think a healthy pregnancy, most people would think about as having a good maternal outcome where she stays healthy throughout the pregnancy and after delivery, and the baby also is born healthy. I think that's sort of like the big picture. When we talk about goals and talk about goals for mom, I'm like, listen, your goal is healthy mom, healthy baby, right? That's sort of it. Now, anything can happen, right? Things can change. You could start off with not a single underlying medical disorder. You're 28 years old and this and that, but then things happen and things change. But I think the bottom line really is just having a healthy outcome and staying healthy after delivery.
Yeah, I completely agree. To what extent do you feel, and then I'm going to point this to you, Anna, to what extent do you feel like there needs to be a shift in our thinking about healthy pregnancies to preconception?
It's so important, right? So everybody really should talk to their OBGYN prior to getting pregnant, right? Because you want to see there might be underlying conditions that you can make a pregnancy even healthier, right? So if you unmask somebody with some, they change, and you know this even better than I do, they change what the guidelines are for like stage 1 hypertension. So you might identify somebody with that who was never diagnosed with high blood pressure before, or somebody who's pre-diabetic, or somebody with polycystic ovarian syndrome who really hasn't impacted on their life so much, but maybe that puts them at a higher risk for gestational diabetes later. So the preconception visit is super important. Somebody who's obese and, maybe they're thinking about getting pregnant in 2 years from now and has the luxury of weight loss, and maybe they'll go on a GLP-1 or something like that, for some time before conceiving.
Yeah.
So I think that's a lot of it.
I'm going to come back to that, but before that, Anna, now you are an OBGYN, but now much of your practice is in midlife and predominantly GYN. To what extent do you take a pregnancy history? And is it because you're so trained to do so, or to what extent do you feel like it bears relevance to seeing women later on in life?
I think, it's a pregnancy history is essential to understand for a woman across all stages of her life. So I routinely ask about number of pregnancies, types of pregnancies, their outcomes in terms of what we call delivery mode, so vaginal delivery versus cesarean delivery, but also complications of pregnancy, because we do understand now that those provide really an essential window into someone's current and future health. So things like a history of what Joanne said, high blood pressure disorders in pregnancy, preeclampsia, gestational hypertension, gestational diabetes, even postpartum depression heightens the risk for certain sort of emotional states later in life, particularly across the perimenopausal transition. So I'm a huge advocate for actually including thorough pregnancy history in any medical intake, and that's something we have a lot of work to do in.
And when you're taking that history now, to get to that same question, do you sort of, I think you already touched on some of the details that you wish to gather, but what does a healthy pregnancy mean to you?
It's a great question. And I would even go a little bit further with that. I think of healthy pregnancy the same way I think about health. And there are different ways to think of that, right? Health can be absence of disease or a complication. This is what a lot of our medical system is geared towards. Even in a preconceptional visit, let's make sure, check, you don't have thyroid disorders. Check, you don't carry some abnormal gene. Check, your immunity to varicella is good. You know, it's really kind of ruling out the presence of certain abnormalities. I think a healthy pregnancy and health is really the presence of a more optimized state, knowing that none of us are ever in kind of this perfect health, right? So healthy pregnancy to me means for sure one where a woman is supported before that pregnancy, during pregnancy, after pregnancy in many different ways. When she is supported socially, when she's supported emotionally, when she's supported medically, certainly, and when she's aware of the changes in her body, too. And a lot of that falls under medical care and prevention and treatment of complications. But there are aspects to a healthy pregnancy that are much more sort of centered on social support and emotional support, too.
I love that, and I think, in a prior conversation that we had, we talked about some questions that we should be asking patients. We may think that everything is going fine, they're healthy, but maybe we need to ask, like, is everything going okay? Are you facing any challenges? Like, some of these things that we need to elicit, because maybe that's going to bring up certain things that we've never thought about. We think everything is perfectly fine, but in fact, they're having stress about certain issues. I just had a patient today whose father was diagnosed with an unfortunate brain tumor, and she's moving, and so that that stress sort of has come out just by sort of asking some questions about like what's going on in your life, right? So
being curious.
Yeah, being curious.
I love that. To what extent do you think that women are actually making these preconception appointments? Is it more that, and is it that we're self-selecting, or they are self-selecting themselves because they're worried about XYZ? Do you think it should be something that we mandate or we encourage more so? Or are you finding more so that people are like, hey, look, I'm pregnant and now I need to see an OBGYN?
I think it's probably more common that they find themselves pregnant and then go for their first visit, right? But I think the more we can get out the awareness of the importance of that preconceptional visit, would we be doing such a service to patients, because it's a half hour, 45-minute, maybe sometimes an hour-long conversation, but it can really dramatically change the outcomes. And, people have questions about maybe medications that they're on or what vitamins they should take. Or we talk a lot about, if you're on Instagram or TikTok and you see everything about all the different supplements, like, should you be on this and that? So it's really would be wonderful for it to be mandated.
Yeah.
But I think we can at least encourage it, and maybe through this podcast get the word out how important it is.
I agree. I think that is an essential visit, just as essential as, seeing a teenager before she goes off to college. Like, I think that should be a really important visit to help prepare her for kind of more education and making certain decisions and handling certain things that she's going to need to handle. But it's another story for another podcast. But preconceptional visit can be extremely useful to somebody in terms of understanding their own health, modifying certain risk factors, optimizing that pregnancy outcome, but also reducing anxiety. People have access to a lot of information these days, and a lot of information can be confusing and conflicting, and that visit can be used to allay some of that anxiety. And then the other side of that coin is also that that visit can highlight certain things that may be more urgent. I cannot tell you how often I've seen patients who may be 42 and they say, you know what, I'm going to try to get pregnant next year. It's not time yet. And we do need to address certain really biological realities there that are really important. And that visit may be the one that actually changes that person's trajectory and the success of her plan.
I think that's such a paradigm shift. I mean, when we've got it in our heads that we've got to get mammograms and we've got to get colonoscopies at 45 now, why isn't it that we really kind of advocate for that preconception visit? I think that that's a shift in our thinking that would be beneficial to so many for all of the reasons that you all mentioned. So now moving into the actual pregnancy. I can see you smiling, Joanne. She's like, yes. So at what level, we all know, oh, you're pregnant, you're going to have pain, back pain, you're going to be exhausted, you're going to be moody, you're going to need more sleep. What are some of the thresholds around those specific symptoms where you feel like it's important to normalize for a patient, but then you also want them to understand the boundaries of what might feel excessive?
Yeah. Great question. I mean, one thing is, yes, these things are normal, but you don't want to normalize and dismiss, right? Like, round ligament pain, that's something where people feel it in the groin. It's typically around 20 weeks. It's a ligament that goes from the labia to the top of the uterus. It gets stretched, and people say, oh, I'm having this groin discomfort. It's just round ligament pain. Well, it freaking hurts.
It hurts.
It hurts.
Hell.
So it does, right?
I've heard.
And like, hemorrhoids, those are, that's a common symptom. Just take some Metamucil and, whatever, and use Preparation H or whatever. But it's really uncomfortable. And so I think we shouldn't be dismissive. We can say it's normal, but not be dismissive. And also give them good advice of what to do. If you are constipated and you want to prevent hemorrhoids from occurring, give them really good advice about high fiber diet and increasing your, being hydrated, taking stool softeners, all that stuff. So I think we need to acknowledge, yes, it's normal, but don't dismiss it. On the other hand, what you asked about certain pain, that's certain things that maybe are more than normal. I think we have to take that seriously, right? So some things that need to be treated, like people get swelling in their wrists later on in pregnancy. It's carpal tunnel syndrome. I mean, sometimes that can be so severe that they really need treatment. So we need to sort of know when it's at that severity where they may need to see a hand specialist and maybe get steroid injections or something, something like that when traditional therapy hasn't worked.
Right.
I also think, there's a difference between normal and common. I think we often say just because something is common, we call it normal, right?
That's a great point.
But that doesn't mean that something that's common doesn't cause suffering or is not an issue. And I think in pregnancy, there are some things. I'm going to draw back on my memories of being an obstetrician many years ago. We used to kind of divide up these things into two different categories. One was sort of issues and abnormalities that would potentially could be very worrisome. Let's say bright red vaginal bleeding, right? Or if you have started to feel your baby move, something like decreased fetal movement. And then you have a whole host, Joanne, like you said, of things that are common, so people often dismiss them. Oh, everybody's got that. You're pregnant.
Right.
Of course, just
that's
put up
what
with
feels
it, right?
like. Right.
But there are solutions. There are ways that, we can prevent some of these things from feeling worse. So I would be very careful about like drawing that line between normal and common. Yeah.
I like that a lot. Do you feel like a lot of that is contingent on you as the practitioner to ask those questions, especially ones around like round ligament pain, groin pain, or hemorrhoids, for example, which is not exactly something that you think, you're proud to disclose at parties, right?
Yeah.
There's so much,
not cocktail party conversation.
it depends, right?
At mom night out, that is what you disclose.
A little urinary incontinence when you cough,
But there is, depending also on your upbringing, cultural backgrounds, there can be a lot of shame around talking about some of these symptoms and some of these occurrences that are common in pregnancy. To what extent do we need to raise awareness about this for our patients and for each other? And to what extent do you feel like it's really just the onus is on you as the doctor seeing that patient to ask those specific questions?
I think at a first visit, you can sort of outline some of the things that you may feel. We go through things like medication use, lifestyle, the fact that, yes, you can color your hair. I mean, I learned that lesson, my very first year of being an attending when I had a patient whose gray hair was down to here, and the third, like she was like due in a week. And I'm like, you could dye your hair. And she's like, why didn't you tell me that? Right? So we go through a lot of these things, early on, and like, what are the medications that you can take that are over the counter? Travel, right?
Sushi, yes.
Sushi,
hot tubs,
exactly, exercise. But we. I think it's a great idea to go over some of the common symptoms that you may experience in each trimester, right? We talk about the nausea and the fatigue, overwhelming fatigue in the first trimester. Some of the other symptoms like we talked about around ligament pain or just lots of pelvic pressure, sciatica. If we give them some of that information ahead of time, at least they'll be a little bit alerted to it, and then, ask them open-ended questions. How are you feeling? Is anything bothering you? Are you in any pain?
Right.
I think it also opens the door for people to not be worried about bringing something up, especially if something has really moved beyond that common and into the really sort of pathologic or abnormal state. And nausea in the first trimester is a perfect example for that, of that. There are some women who are somehow lucky and don't ever feel it. I don't know. I was throwing up multiple times a day, every day for 20 weeks. God. So I was on the other end of the spectrum, but plenty of people are in the middle. Do they need medications, or do they need a little bit of ginger and adjustment in how they eat? That's that group, but they should also know the tools they have. But just opening the door to this will allow the women that are experiencing those severe symptoms to get treatment and not be afraid to speak up.
Right. I think that distinction between it being common but not dismissed is so important. And going back to that preconception visit, that's also a way for you to develop this rapport with this practice individual who's hopefully going to carry you through for the next 9 months and beyond, right?
You know what? You must have read my mind, because I was just going to say that's a great opportunity to kind of, test drive that practice.
Connect or not.
What's your connection? What is the vibe? What is the approach? Is that, a lot of people in pregnancy, I'm sure, Joanne, you see that, have certain philosophies and approaches to how they want to be taken care of, the beliefs around the use of pain medication in their labor and so on. This is a good opportunity to see if the practice aligns with your own personal medical philosophy. Also understanding that we can't control how pregnancy goes in the end.
No, you both bring up a great point. And I think as obstetricians, sometimes we don't address like the birthing plan until the third trimester.
Right.
Well, it could be something completely different. Like there's some practices that may not want to have somebody who had a prior cesarean delivery attempt a vaginal delivery. Well, you're going to wait to the third trimester to ask that question, and then you've been in with the wrong doctor or practice, for the whole time. Or And expressing some people that maybe they're better off with the midwife, right?
Yeah.
There are goals.
I think that, that pregnancy, the pregnant person obstetrician relationship is one of those very special relationships in life.
Yeah.
It's special on both sides. So, yeah, I think it's a great opportunity for a little blind date there.
I like that.
Yeah.
Speaking, before I go into my next question, you actually brought this up, and I don't know the answer to this, and you hear so many different things. So once you have had a delivery via cesarean section, can you have a vaginal delivery? What is the consensus around that, or is it really practitioner dependent?
I mean, part of it depends on the kind of cesarean, right? So if you had a cesarean, maybe you were 26 weeks pregnant and you had what we call a classical cesarean, which is a vertical incision on the uterus, not on the skin, but on the uterus. That's a contraindication to having a vaginal delivery, right? So that is like one absolute, right? There are other things that's a discussion with the patient. So if you had a cesarean because you got to fully dilated, you pushed for 4 hours, and you didn't deliver, your chance of success is not zero, but it's not as high as somebody who had the first section because the baby was in the breech presentation, which has a much higher success rate. So it's that conversation. It also is like, how many children do you want, right? Because we know with each cesarean section, there's more scar tissue, there's greater chance for abnormal placentation. So it's a lot of these factors that we need to talk to patients about. What are their desires? Some people are like, I had a section. I don't want to ruin another part of my body, so let me just do a repeat section, right? So, because...
And I think, it's a big discussion, actually, because it has to take into account all of those past sort of history details, but also future plans. So it's kind of looking like into a crystal ball of like, how many times are we going to do this, right? It also has to take into account just this kind of personal philosophy. No, somebody who could have had a cesarean section after prolonged labor and the baby's heartbeat went down, it was this massive emergency, caused so much stress and anxiety. They could be like, you know what, I don't want to go there. I want to schedule, 8 a.m. I'm showing up that day. I don't want the drama. It was terrible. And then there are other people in that position who really, really want to try, and they have a good chance of success for a vaginal delivery. So I think being, again, nuanced conversation and being on the same page while practicing safe medicine and not doing something harmful for either mom or baby it's all goes together there.
It's so amazing how these are like constant reminders of how not protocolized aspects of medicine, particularly in this case of a healthy pregnancy, are. So I thank you for that little detour. So what about individuals who are on medications prior to conceiving and now show up at your door saying, listen, I'm pregnant, I'm on semaglutide or Wegovy or Ozempic or Mounjaro or whatever they happen to be on, a GLP-1.
Yeah.
What do you tell them?
Yeah, so, that's the ideal candidate, and certainly also depends on which medication they were on, because some have longer half-lives that stay in their body. But that's the ideal patient who should come for preconceptional consultation, right? Because
so true, so true.
We don't have any really good human safety data on GLP-1 use during pregnancy. They're told to stop the medication, right? And ideally you want to stop it preconceptionally. We do know that there are some benefits in terms of achieving a pregnancy. So patients who have lost weight, maybe they had polycystic ovarian syndrome, and are better able to conceive, right? We see that.
Right. That's the irony.
That's
right?
the irony.
You're like,
right?
That's how I got here.
Exactly.
And now you're telling me to stop it.
That's right. But that's what we have to tell people now, because we don't have the safety data, and we don't know the long-term effects on the fetal brain and things like that. And it's a struggle because people lose weight. If they were on it for weight loss, then you have to, they're gonna gain more weight. There's studies that show that if they're on it because they were diabetic, then you have to switch them over to safe, medicine, insulin or metformin or things like that.
That's been studied. I mean, as a cardiologist, you know this. I've been dealing with this, just happened ironically in the past 2 weeks, where I've had patients who have needed the GLP-1 for cardiometabolic health. It may or may not have played a role in increased fertility, and they show up, and now I'm having to peel back on a medication that I know offered and conferred benefits from a cardiovascular perspective.
It's such a, it's a perfect example of how complicated things can get in medicine so quickly. Because on one hand, especially with GLP-1s and pre-pregnancy weight loss, especially in something like PCOS, which is such a common endocrine disorder, and using a GLP-1 can lead to significant weight loss and correction of certain metabolic parameters and processes that then will subsequently result in greater ovulation rates, greater pregnancy rates. Plus, we know that being overweight and carrying too much weight prior to pregnancy, right? It gives you all the heightened risks of everything from hypertensive disorders to delivery complications and so on. But yet, we really don't know how a GLP-1 will affect that fetus and subsequently that person, and whether it will have any long-term effects on their metabolic system later in life. So it's a really, we're kind of out on the open ocean here without knowing, and it's really difficult, I imagine, to have this conversation.
Yeah, I mean, I think that the data that will first come out will be on fetal anomalies, because people will have conceived, right?
Right.
And then they'll stop at some time, maybe in the first trimester if they get into prenatal care early. So there'll be registries, and and there's currently no known, although not enough studies out there, there's no known impact on fetal anomalies right now or teratogenicity, but everybody's stopping it early, so we're not going to know the long-term outcomes. I'm not sure.
To be honest, I did too.
Yeah.
Yeah, it would be so interesting, right? If some people continued it for whatever reason, the practice is now to stop it. Is it impacting childhood obesity rates?
Right.
Is it,
Risks.
we just don't, it's impossible to weigh those, right?
It also speaks to, this is a passion of mine, as a clinical trialist. Forget the underrepresentation of women broadly, but how little we know about what is safe and what is not safe in pregnancy. Do you find that to be a struggle? I mean, you've been president of MFM societies nationally, internationally. Where do you feel like we are with our understanding with what is quote unquote safe and not safe during pregnancy?
It's such a huge thing, because pregnant individuals were considered vulnerable populations, and really pharmaceutical companies don't want to include them in studies because of the risks of the legal risks, right? And so it's really problematic, because so many of these medications have never been studied in pregnancy. So we really don't have enough information to give to patients on the safety. So it's problematic, and ethical. And then there's ethical discussions.
Right.
You want to do randomized trial? Do you want to randomize people to stopping the GLP-1s or continuing? And who's going to do that? Who's going to do that study? And so it's really problematic. It's one population. Well, that and children also. There are a lot of studies that have not been done in children on medications.
It's such an ethical conundrum, right? Because we tend to we tend to operate from the assumption of healthier mom, healthier baby.
I was just going to get at that.
And most of the time, that actually turns out to be true, right? We're even seeing that with certain, let's take depression, right? It's not healthy for a mom to be severely depressed in pregnancy. And because of that, we do use antidepressants. It may improve bonding and therefore even neonatal and infant outcomes. But some drugs are not like that. So maybe healthier mom through the use of certain pharmaceuticals doesn't mean healthier baby. And we've gone down this road before, like the whole thalidomide story and all of that. It's very, we just don't know.
Yeah.
So I'll leave it up to the smarter people in the room, like Joanne.
Well,
or the one that least does deliveries.
what are some of the the most common things that you hear people Googling at 2 a.m. during their pregnancy? Is it that they're, saying that they're super horny and they're looking up why they're having sex dreams? Is it the round ligament pain? What are some of the common things where you're like, don't worry, you're not alone?
Yeah. I think sometimes it's, just waking up at night and not be able to get back to sleep. I think that's one of them. The sex dreams is a thing. I mean, people do have very, very vivid, sex dreams, which is good for you. If you is it okay? It's okay. Yeah, exactly. It could be fun. So those are like some of the sort of easy ones that people do. Anything that they're worried about.
Food is definitely like top of mind. Can I eat this? Can I eat that? One of the questions I once had was,
I'm laughing preemptively. I don't know why.
I had a bite of a poppy seed bagel, and I'm worried about potential opium dependency or addiction or something like that. I'm like, okay, it's not going to come from a poppy seed bagel, but so, and I think people don't know and get anxious. And, pregnancy is also a time where a lot of women try to be perfect because they're hyper vigilant because they think every single little thing will affect that baby. And I just want to say, that's how you think on your first baby. Your second baby, you're like, I'm having my third cup of coffee. And where's my salmon roll?
Right. And we've gone through some myths in a prior conversation. Quick yes, no's. Sushi, yes or no?
Yes. Like limit the tuna and no raw shellfish.
Okay, I like it. We've got the expert here. Wine, yes, no.
Well,
Tricky.
the societal recommendations are to avoid all alcohol. Studies really show more than a certain amount of alcohol per day puts you at an increased risk for fetal alcohol syndrome. So I think I tell people once in a while, once in a while it's okay. A lot of people really are just like, absolutely not. I would never, like there's so much out there. And again, the recommendation is to avoid all alcohol, but in all likelihood, once in a while is okay.
Sex during pregnancy, yes, no.
Yes. Yeah, I mean, there are some rare exceptions. Someone with a placenta previa, for example, after a certain time, I think. Somebody with, again, I haven't delivered a baby in 7 years.
No, you're right. After like 28 weeks.
After 28 weeks. Somebody, again, with complications, premature rupture of membranes, let's say. Otherwise, go for it.
But
Is that what you say?
Yeah, no, I do. But it's interesting because, like, there's some people that just really are like, I mean, it's either the patient or the partner who are really squeamish. Like, they think that the fetus is going to know what they're doing and are, like, going to be horrified or embarrassed or something like that. So
He's just not going to know.
Yeah, I know. Like, but, like, it's, for some people, it's like, I told my husband, no, there's nothing. You're not allowed to have intercourse after like 12 weeks.
That's the data.
That's it. Yeah, exactly.
Masturbation during pregnancy, yes, no.
Yeah, so it's a really good question. So people ask that a lot if they had a history of a prior premature birth. There's no data that having an orgasm is going to cause you to go into preterm labor. So it really is totally safe. And why the heck not?
I like this. Old wives' tales that refuse to die. Okay.
Yes.
Pedicure. Yes, no. Allowed, not allowed.
Reflexology on the feet.
Potentially leading to...
Allowed.
Allowed.
Yeah.
Allowed. Even third trimester, second trimester, you don't care. You can get your pedicures.
Listen, your legs are going to be in the footrest, and you're not having socks on, so you want your nice toes. Exactly.
Beautiful.
And you're not going to have time after the baby's born to go ahead and get a pedicure.
Coffee? Yes, no.
Yeah, up to 150 to 200 milligrams.
Okay. Travel? Yes, no.
Yes. It also depends. It depends on how your pregnancy has been going. Again, if you have certain pregnancy conditions where you may end up in the hospital at any given point, that's something unpredictable. Do you really want to be out, I don't know, ziplining in Costa Rica? Like, probably not, right? So I think in those circumstances, no. And probably when it gets closer to your delivery, you probably want to deliver with the people you've met that have been taking care of you. So I probably limit travel then. But
I imagine you'd get that question a lot, right? Around baby moons.
all the time.
What
All the
island
time.
is okay for me to go to? Can I fly to Paris? I mean, this is uncertain.
It
Some
rained
people,
for
if they have
7
that
days
luxury.
straight on my baby moon.
Oh, brutal.
And I didn't have any alcohol, and then I got salmonella poisoning. So also be careful.
Yeah. No, it's true. I mean, especially when Zika was really prevalent, we had lots of
remember that.
questions
Zika,
about
I
Zika
remember.
travel. But I think what you said is really important. It's like, when is it? Where are you going? If it's a quick trip to Florida or visit parents in Maine or something like that, and you're 34 weeks, it's probably okay. If you're really going to go to some remote island where it's really hard to,
Get back.
that's more of an issue.
Yeah, so it's not entirely straightforward. I think this is why these questions keep coming up, right?
Yeah.
One thing I want to end on. We have talked a lot about what a healthy pregnancy means, mom, baby. We have all kinds of families, all kinds of ways of getting pregnant. To what extent do you feel like a partner, and that can come in many different forms, even if it's not necessarily a lover of a partner, plays a role in the healthy pregnancy for a woman?
I think having somebody that's like an emotional support is really important. I mean, people do this on their own without a partner, but they can bring their mom, their sister.
Yeah, that partner doesn't have to be a partner.
Exactly. But, it is going through something, especially if it's a first time, going through something that's, unknown to you and, unexpected. So having somebody that you can rely on to be there for you, I think is super helpful.
I think that support also can show up in so many different ways. That support can show up at a prenatal appointment, somebody who can ask follow-up questions or maybe can ask something from a different perspective and can remember something differently. That support can show up as like a cup of tea at night. That's great, nice, versus having to deal with the evening alone. That support shows up in labor, and that support can show up later as just help in many, many different ways. So I think, and I think we've talked about it in other podcasts, just having support, period, is healthy for us.
Do you advocate for that kind of support, or do you ask about a woman's support system around pregnancy? Do you feel like it's, sort of incumbent upon us to do so for those reasons?
I would, again, I will defer to the maternal and fetal medicine expert here. I think it's hugely important. I mean, there are programs built around this because we know that lack of support during pregnancy and after pregnancy is linked to worse outcomes. So having, almost baked in ways of asking about that during prenatal care and in the hospital around the time of delivery is hugely important. And being able to rely on certain support networks, including social support networks, is important. It's important to identify the patients that will benefit from that.
Yeah, I think you're right. And, if you think more broadly across the country, even, internationally, there are areas where there are maternity deserts where it's really hard to get to an appointment or it takes 2 hours to get to, those, especially in those areas, people need, I think, a support system that can help get them there or help, make them to their appointments or be there during, pregnancies that might end up being, they're starting off healthy, but they may be at higher risk
you
after.
just don't know
You
exactly how it's going to go. So I think that's hugely important. So we're going to close. I want to give you both the opportunity for a last word. If there was one thing that you wanted women to know about a healthy pregnancy, what would that be? If there was one takeaway from this episode that you want people to leave with, what would it be? We'll start with Anna and then we'll end with Joanne.
Okay. I would say this. As an OBGYN, but also as a mother. You start being a parent when the second you find out you're pregnant, maybe even before. And part of parenthood is releasing control over certain things and acknowledging the fact that we can't control everything. So while it's important to know and read, inform yourself, not be dismissed, bring up issues, and be very active in your own health, there is a degree of lack of control over the process, and we need to be okay with that.
I love that. Yeah, I was thinking sort of on a similar.
That sounds depressing. So
No.
I hope not.
Yeah, because I think the flexibility is super important, right?
Resilience.
Yes.
It's a resilience, and things may start off, without a hitch, but things can change, and complications can occur, and so we have to be open and well informed, but also understanding that things can change. I mean, you hope for the best and all that, but and I really don't want to end on a depressing note at all. Most pregnancies end beautifully with like this beautiful bundle of joy in your arms, but like you said, be flexible, be open for things to come up, and know that you can ask questions, and hopefully you know that you're with a good practitioner who's going to get you through it safely.
Yeah, there's an element of surrender.
Yeah.
Yes.
Right?
Yeah, that's
And
beautifully said.
I think that's also so beautiful for an OBGYN. And this is actually what I wanted to do originally before I went into internal medicine and cardiology. I think there's this
time.
Will you take me, Jen? I feel like there's this beautiful responsibility and opportunity in this. So I thank you so much, both of you. I always learn so much from you. And looking forward to our next episode.
Us too.
Thank you.
That's it for this episode of HERology. I'm your regular co-host, Dr. Anu Lala. For more groundbreaking conversations on women's health, subscribe to Mount Sinai Health System's HERology podcast on YouTube, Apple Podcasts, Spotify, or wherever you get your podcasts. HERology is a production of the Mount Sinai Health System and the Carolyn Rowan Center for Women's Health and Wellness. To learn more about the Rowan Center and our state-of-the-art facilities helping shape the future of women's health, scan the QR code on your screen or click the link in the description below.